Hi, everyone, and welcome to today's webinar on the implications of the end of the public health emergency for Medicaid enrollees. I'm Tara Oakman, Interim Managing Director for our Health Systems theme at the Robert Wood Johnson Foundation, the nation's largest philanthropy dedicated solely to health and health equity. The foundation is 50 years old and has from the start been a trusted and nonpartisan source of information on policy aimed at improving health and the healthcare system. Today's conversation is focusing on the expected expiration of the Department of Health and Human Services COVID-19 public health emergency and what it could mean for individuals enrolled in Medicaid. Before joining the foundation, I worked at the Centers for Medicare and Medicaid Services, where I oversaw implementation of several sections of the Affordable Care Act. This gave me firsthand experience in the complexities of navigating policy implementation and the enormous impacts every policy decision can have on real people's lives. Preparing for the end of the public health emergency and what it could mean for people enrolled in Medicaid is one of those moments. It presents a complex policy challenge where implementation decisions and planning, or lack thereof, will have real implications for people's lives and for their coverage. As many of you know, Medicaid is a critical lifeline for many individuals and families and has been especially during the pandemic. As you will hear from our speakers, the federal COVID-19 response legislation required that states could not disenroll people from Medicaid while the public health emergency was in effect. But this public health emergency is set to expire later this year. And when it does, nearly 16 million people, disproportionately communities of color and low-income individuals, could potentially lose their Medicaid coverage, not necessarily because of ineligibility, but for many reasons that our speakers will get into. So making sure that people continue to have access to affordable health coverage is perhaps one of the most urgent issues of the day. Thankfully, there are opportunities for federal policymakers to support state Medicaid and agencies and help minimize coverage losses. Unfortunately, we are still in the middle of a pandemic, but fortunately, the extension of the public health emergency does give state and federal policymakers time to prepare in order to help as many people as possible maintain access to life-saving health coverage. So to discuss this in greater detail, I'm so pleased to introduce our speakers, Patricia Boozang and Tricia Brooks. The first speaker, Patty Boozang, is a senior managing director at Manatt Health Solutions and a technical assistance advisor for the Foundation's State Health and Value Strategies program. In these roles, she advises states on a wide range of health coverage issues, including Medicaid expansion, design, and implementation. We are so lucky to have Patty with us. Patty, over to you.
Thanks, Tara. Thank you so much for that nice introduction, and I'm really pleased to be here with you today. And I think we're going to pull up some slides. I'm not going to go through all of these in detail. I'm going to just offer a few overarching comments, and then you will get these slides in follow-up. So one thing I will just say to set a little bit more context is in my role working with State Health and Value Strategies, which is a technical assistance program for states, is that we have been spending really 90% of our time over these last many months focused specifically on helping states prepare for the end of the PHE and more specifically the end of the Medicaid Continuous Coverage Guarantee. So I hope to offer you some insights as to what we're seeing out there among states who are trying to get ready for this really significant coverage event in our country. So I think we can go to slide 2. Tara did a great job of explaining what the Medicaid continuous coverage requirement is. I'm just going to say a little bit more about it, which is it's one of the really essential things that Congress did to help states and to help people in the country during the COVID public health emergency. Basically, what this provision of FCRA says is that anybody who is enrolled in Medicaid as of March 18th, 2020 or since stays in the program, regardless of changes that may have occurred that impact their eligibility. And that's a condition of states receiving enhanced federal Medicaid funding, and that condition will stay in place through the end of the month in which the public health emergency ends. I'm going to do something that someone told me to do long ago, which is to sort of tell you at the top of my remarks what I want you to leave here remembering The first point is that it really is impossible to overstate how important a coverage event this is in our country, and the risks of people of the country losing ground with the coverage levels that we've been able to reach through the pandemic. The primary goals, as we've been working with states, and we think these are goals shared by the vast majority of state Medicaid agencies, and certainly by our partners in federal government, are to ensure that people maintain health coverage for which they're eligible as this Medicaid continuous coverage guarantee ends. Whatever they're eligible for, if they remain eligible for Medicaid, we want them to stay there. If they're eligible for subsidized QHP coverage, we want them to get that seamlessly and not have gaps in coverage, and so on. So whatever they're eligible for, we want to make sure they get it and they keep coverage. We also want to prevent the end of the public health emergency from exacerbating what we know are already widespread racial and ethnic disparities in our healthcare system, and I'll talk a little bit more about that. Success in this endeavor is really going to take mutual and sustained partnership of states, of HHS and CMS, our federal partners, and of community stakeholders, both sort of national organizations, but also boots on the ground people and organizations who can really help people to get connected to and stay connected to the coverage for which they're eligible. And the last thing I'll say is that we shouldn't be narrowly focused on the end of the PHE. Certainly that's our biggest priority, is being ready for this big coverage event. But we should also think about what are changes that we can make that in the long term will help people retain their coverage. It's a really essential and possible thing for us to improve coverage retention in our country overall. So I'm going to go to the next slide, which is an illustrative timeline. The federal PHE is currently slated to end on July 14th, July 15th time range. We know that because HHS hasn't given us notice that it's going to end, they have promised to give states at least 60-day notice prior to its termination, that it's likely the public health emergency will get pushed out to October or even further. And I would just say that uncertainty regarding the end of the public health emergency has been one of the big challenges to states who are sort of primarily responsible for implementing this unwinding at the end of the PHE. Really what we're saying is that when the PHE ends, that end of that continuous coverage requirement, states are going to restart Medicaid determinations for everybody in their programs. And we anticipate that, well, we know states can take 12 to 14 months to complete that process, but it's going to be a very, very significant undertaking. And it's not going to be happening in isolation. Marketplace open enrollment is going to be happening. States have lots of things going on in their Medicaid programs, in their state budgets, lots of things in the environment that are going on at the same time they're taking on this huge effort. Most states would say to you that more time is better in terms of preparedness, that they'd like to have until the end of the year to get ready. I will point out, and I suspect Tricia will talk about this too, is that certainly the PHE and keeping people in Medicaid who are potentially ineligible are pretty politically charged topics. So there are certainly some states where we're hearing rumblings that the PHE should end, and we can talk a little bit about why those rumblings are happening and how we think that will play out. So turning to the next slide, just to give you a sense of the scale that we're talking about here, the stakes are very, very high for coverage loss at the end of the PHE. States are going to need to redetermine eligibility for nearly all of their Medicaid enrollees, and that enrollment has grown by about 20% on average across the country. Some studies are predicting that as many as 16 million people could be disenrolled from Medicaid, and an estimated third of those losing coverage could be eligible for subsidized marketplace coverage. So the disruption here is huge, and the risks of disruption to care are particularly huge and particularly concerning as we think about retention of coverage. So turning to the next slide, and Tara alluded to this, but we really want to talk about the disproportionate impact and keep a focus on the disproportionate impact that coverage loss could have on communities of color in our country. People can lose Medicaid coverage at redetermination for two reasons. One are procedural denials. That means we didn't really have what we needed to redetermine your eligibility, and you as the beneficiary didn't respond to our request for more information. And so we're going to terminate your coverage because all of things being equal, you haven't demonstrated to us that you're still eligible for coverage. People can also be terminated, obviously, because they have some change in their family circumstances that makes them ineligible for the program. Communities of color in our country are at disproportionate risk of coverage loss for both of those reasons. These populations are overrepresented in the Medicaid program as a percentage of the population, but our lower income communities of color have also experienced more economic volatility, more housing instability, which leads to problems finding people and their ability to demonstrate their ongoing eligibility. So we need to care about this coverage event for lots of reasons, but including because it could exacerbate health inequities in our country. Turning to the next slide, I'm going to kind of go quickly through these next few slides, but what I want you to take away from this is that the Biden administration is really taking an all-of-government approach on being ready for the end of the public health emergency and the end of the Medicaid continuous coverage guarantee, helping states get ready for those events. There really has been, I think, unprecedented partnership with states to try to get ready for this, and a high level of guidance, of direction, of requirements to states about what they should be doing to get ready, how they should be planning, some parameters and guidance which tend to be consumer protective of how they have to do this unwinding. And I think in short, what I would say is CMS is telling states, take time, plan now, have a plan, take the longest time available to you, which is a 14-month period, to complete this redetermination process. And I would say that most states are paying a high degree of attention to that planning. Some states have state legislatures or governor's offices that are requiring their Medicaid agencies to go fast, that are saying, we want this to happen in 6 months, not 12 months. We want you to focus on getting ineligible people or potentially ineligible people out of this program. And that's very challenging, and those are states that we're all watching, and I think we have a concern about inappropriate loss of coverage in those states. So turning to the next slide, I think here you can review at your leisure, but I would say the point here is that marketplaces also matter in this, given that we have a third of people eligible to transition to marketplaces. So Medicaid agencies need to have their systems and operations and workforce ready to be doing all these redeterminations. But marketplaces, including healthcare.gov, also need to be ready to sort of catch people who appropriately transition to the marketplace and determining their eligibility for subsidies. And that really requires for marketplaces a different level of communication, perhaps different outreach and support, and engagement with community organizations, navigators, assisters will really be essential across both Medicaid and the marketplace. We can turn to the next slide. This is just a summary, again, speaking to my comment that there's been this sort of unprecedented level of focus and attention with our federal partners on unwinding needs, and this is sort of a summary of some of the activities that have taken place. A really high degree of engagement between and among CMCS and CSIO and those federal agencies and their counterparts in states, which I think is so critical for us to sustain to do this successfully. So just turning to my last slide, I want to talk for just a minute, and I'm going to pull up another file so I can consult some specifics, talking about what are some of the state strategies to ensure coverage retention during unwinding. Certainly, as I said, states are getting their systems and processes ready, getting their workforce ready. Hiring workforce is a very big challenge in states. We're hearing that everywhere in terms of, what are you worried about in terms of being ready for this? But states are really trying to improve their data sources to validate eligibility, their communications plans, et cetera. I would say the three really important things or innovations that states are taking up include stakeholder engagement, again, working with community organizations and stakeholders. And here I would point to a couple of model states. Massachusetts legislature funded healthcare for all in Massachusetts to the tune of $5 million for a community-based outreach and education campaign. It was based on some work Healthcare for All had done during COVID. New Mexico is working with a vendor to identify Medicaid CHIP enrollees who are at high risk of coverage loss and sharing their data among community organizations to support outreach. So really important engagement activities there. Communications and outreach, so developing targeted and specific communications plans that are being rolled out now through the end of the public health emergency. New York State has a really powerful media campaign that they have implemented. Text messaging is going to be a key strategy for states, and there is a letter out for comment that the FCC is considering giving states more flexibility to use text messaging during this period. That will be very important for states. And finally, I'll say there are some states really focused on coverage innovations. California has developed a mechanism to automatically enroll people who are losing Medicaid coverage into a marketplace plan. Oregon is creating a bridge plan for low-income people who are just above Medicaid levels to ensure that they get affordable coverage, have access to affordable coverage. So there are many, many more strategies here that we can point to in terms of state models. And I would just say, I think states really are very focused, and I think as we implement, it will be important for CMS to be monitoring what's happening out in states, what's happening with coverage levels in the Medicaid program, and intervening when there is disproportionate loss of coverage among states. So I'm going to pause now. I think I hit my time. That was my timer you heard going off, and I'll be very happy to answer questions following Tricia's presentation.
Yeah, thank you so much, Patty. So just to underscore your bottom line, it is absolutely impossible to overstate the magnitude of this moment for coverage, but it does not have to be catastrophic. And we can all collectively consider what we can do to help maintain, preserve, and expand access to coverage for people, not just now, but in the long term. So thank you. And
Here, Tara, really, really well said. I mean, if COVID taught us anything, it's that we can do hard things. We can come together as government partnerships with community and really do difficult things. And I think this falls in that category.
Yeah, exactly. Awesome. So thank you so much. And now we will turn the stage over to Tricia Brooks. Tricia is a research professor at the Georgetown University McCourt School of Public Policy's Center for Children and Families. And she focuses there on policy, programs, and quality of healthcare related to Medicaid and Children's Health Insurance Program, or CHIP, and its coverage for children and families. So over to you, Tricia. Thank you.
Thank you, Tara. Really appreciate the foundation asking me to join this conversation. And I'm going to reiterate, but also build on many of the things that Patty had to say. Unlike Manatt and the Chivas project, we at the Georgetown Center for Children and Families work very much with the stakeholder community. We particularly work with child health advocacy and policy shops, as well as organizations such as the American Academy of Pediatrics and the National Association of Community Health Centers. We can go to the next slide, because I'd like to start by picking up a point that Patty made. Millions of people could become uninsured when states begin to resume routine operations after the end of the PHE. So how many people are at risk? The Urban Institute estimated that nearly 16 million Medicaid enrollees, including 6 million children, will be disenrolled based on the hypothesis that enrollment will shrink to a level consistent with pre-pandemic enrollment trends. A Kaiser Family Foundation brief reported data from 2 surveys of Medicaid agencies with vastly different results. Disenrollment estimates ranged from 5 to 15 million. My colleague Joan Alker and I estimated that nearly 7 million children could be at risk for a disruption in coverage based on the 2018 disenrollment rate reported in a recent MACPAC analysis. Urban researchers acknowledged that disenrollment will largely depend on how each state handles the unprecedented volume of eligibility determinations. The Kaiser Family Foundation noted in its survey results that it illustrates the great deal of uncertainty surrounding how states will implement the end of the continuous enrollment requirement and how many people will lose coverage. Whether using state projections, predicting a return to the pre-pandemic enrollment patterns, or using historical disenrollment data to estimate coverage losses, honestly, there is just no easy or simple way to accurately forecast what's going to happen because this is so unprecedented. However, it is clear that there is significant risk for coverage losses ahead. We can move on to the next slide, where I want to talk a little bit about what's at stake. Medicaid and CHIP are the predominant sources of health insurance for children, now covering more than half of the nation's children, or 40 million. And Medicaid is the primary source of coverage for low-income families, rural residents, and communities of color, as Patty noted. Health coverage protects families from medical debt, which is the leading cause of bankruptcy. Medicaid also provides important sustaining revenue for rural hospitals, community health centers, and other safety net providers. In focus groups conducted in February, enrollees were clear that Medicaid has provided necessary and life-changing care. Prior to having Medicaid, most were uninsured, or either they put off the care because of cost. With Medicaid, they were able to schedule delayed surgeries, afford their medications, deal with chronic conditions, and get preventive care, and more importantly, access care at a time when the need for mental health services is on the rise among all ages, but particularly among adolescents. Next slide, please. So what's going to happen at the end of the PHE? This is a graphic we put together for the paper that we did on the loss of coverage for kids. And as Patty noted, states will need to conduct a full renewal of eligibility based on current circumstances. Now, when an enrollee's eligibility is reviewed, there are 3 potential outcomes. Hopefully, most will remain eligible and enrolled. However, some will no longer be eligible, most likely due to higher income. And while a majority of children will likely remain eligible for CHIP, adults and some children may be eligible for financial assistance to purchase a marketplace plan or enroll in employer coverage. But there are barriers to those sources of coverage, including affordability, particularly as it relates to private insurance, and limited enrollment periods, as well as difficulty in applying for financial assistance and selecting a marketplace plan. These individuals will need consumer assistance. But what we're most concerned about is people who lose coverage for procedural reasons and are at risk of becoming uninsured. Next slide, please. So Patty talked a little bit about this, but I want to go into a little more detail. What are procedural disenrollments and why do they occur? Individuals are disenrolled for procedural reasons when the state needs additional information to determine if the enrollee remains eligible. Now, states that maximize the use of available data to renew eligibility without requiring forms or paper documents to prove eligibility will have a lower number of procedural disenrollments. And there are a variety of reasons why people lose coverage without being determined ineligible. Sometimes the mail doesn't even reach them, or the renewal notice is confusing or not in the enrollee's preferred language. If enrollees are not able to get through to the call center, they may run out of time before the state processes the disenrollment. It's also not uncommon for states to lose paperwork submitted by the enrollee, particularly when eligibility workers are overloaded. Enrollees may also have difficulty providing paper documentation, such as income for gig or cash employees. Next slide, please. Now, based on a recent analysis of churn in Medicaid analyzed by Mathematica for MACPAC, over 1/3 of all enrollees under age 65 and 43% of children who were disenrolled from Medicaid and did not move to other public coverage in 2018 re-enrolled in Medicaid within 12 months. Unfortunately, the reasons for disenrollment are not currently captured in TMSIS. That's the big HHS database that is the source of this analysis. Some may have experienced temporary income fluctuations, while many lost coverage for those procedural reasons. Importantly, the MACPAC analysis indicated that state policies and procedures impact churn. States that have 12-month continuous eligibility for children, that do not conduct periodic data checks between renewals, or that have higher rates of automated renewals using data available to the state, all have lower rates of churn. In states with reliable race and ethnicity data, the MACPAC analysis also revealed that the churn rate was higher for Black, Hispanic, American Indian, and Alaska Native enrollees. Next slide, please. Now, according to the Urban Institute, most people losing Medicaid will likely be eligible for some other coverage, including about 27% of adults and 5% of children who may be eligible for marketplace financial assistance. But the question stands as to whether they will successfully transition to other sources. The MACPAC analysis indicates that only 4% of Medicaid enrollees transitioned to the marketplace in 2018. And of those, over 70% experienced a gap in coverage. Now, the ARPA enhanced premium tax credits boosted enrollment, made it easier for people to make that transition, but those are set to expire at the end of the year unless Congress extends them. And while transitions should be seamless for children, the MACPAC analysis revealed that between 15 and 20% of children also experienced a gap in coverage moving between Medicaid and CHIP in either direction. Next slide, please. Despite all of the uncertainty, what is very clear is that millions of low-income children, families, and other adults do not have to lose coverage if states approach the unwinding of the continuous coverage protection thoughtfully, put the right policies in place, and take the time to get it right. And I'll move on to my last slide here because I want to talk about what does that vision of getting it right or doing it well mean? Well, first of all, transparency is a fundamental government obligation to share information that promotes accountability. By understanding the state's plan and being able to monitor key performance metrics, stakeholders are better able to advocate for mid-course corrections that may be needed to avoid coverage losses. But there's no requirement for transparency in either the plan or the key data that will help us understand how the unwinding's going. Secondly, collaborating with Medicaid stakeholders, and Patty lifted this up as well, will not only improve the state's plan, but states will find a cadre of partners who can help amplify key messages and assist eligible enrollees in retaining coverage. It's extremely important to balance the timeline for resuming routine operations with the workload and workforce capacity. The workload will be easier to manage if states take the full 12 months, and doing so will help avoid an uneven distribution of work in future years. States also must have sufficient staffing to do the work and assist families. But like private employers, states are finding it difficult to retain and recruit new eligibility or call center workers. And states risk burning out staff if they are drowning in work, which will only exacerbate staffing shortages. Patty mentioned this as well, a robust communications plan to keep enrollees and all stakeholders informed of what's happening is critical before, during, and after this unprecedented event. And we really need to focus on notices. Confusing notices have been a long-standing concern in Medicaid, but there's still time to review and simplify them. Recent focus groups have helped inform the development of model notices that states can adopt. Renewals have to be processed in a timely manner, but this is only possible if eligibility workers can stay on top of the workload. When workers are overwhelmed, mistakes are bound to happen and paperwork may get lost, which simply creates more work. Another key aspect of this is to send reminders and follow up with enrollees and give them extra time if additional information or documents are needed. And doing so will improve the response rate and reduce those procedural disenrollments. Having a sufficient consumer assistance is really important. Call centers function well when wait times are reasonable and staff are adequately trained to provide prompt, accurate consumer assistance that enrollees will no doubt need. And keeping that share of procedural disenrollments low is important because historically, as we've shown in the data, many individuals who lose coverage for non-eligibility reasons remain eligible but become uninsured. And doing it well means that children and families who are no longer eligible for Medicaid get the help to transition to other coverage. States also need to be prepared to pause and respond rapidly if the data suggests things are not going well. In particular, increases in call center wait times and the share of procedural disenrollments are early warning signs that things are not going well. And last but not least, by working in partnership with stakeholders, states can get intel from the field to supplement those key monitoring data. Establishing bi-directional feedback loops will help keep stakeholders informed and help states identify bottlenecks and recurring problems that need attention. Now that the Biden administration has not given the promised 60-day notice that the PHE will end in July, states have at least 5 months to prepare. And in closing, I really think it's important to reiterate a point that Patty made, and that is to note that CMS, and particularly the Center for Medicaid and CHIP Services, have been doing a tremendous job in working with states and providing as much flexibility as possible to ease their administrative burden and protect enrollees from inappropriate terminations. And with that, I'll turn it back to Tara and look forward to further discussion. Thank you.
Yes, thank you so much, Tricia. And I want to come back to, where you ended and also where Patty ended about what states can do and what states are doing. And it can seem like details, process, but as I said at the beginning of my remarks, those decisions and implementation are and will be and continue to be absolutely critical for people's lives. And as you said at the beginning of your presentation, Medicaid and having access to health coverage has a major impact on physical health, on behavioral health, and on financial health, which is critically important. So thank you again. And now we are going to turn to taking questions from the audience. As it says in the chat, to ask a question, click the raise my hand button at the bottom of your screen. And there are also directions if you are on the phone. Since you might not see the chat if you're on the phone, I'll just say select *9 and then we will call on you. So our first question this afternoon is, how can policymakers address equity issues as they plan for the end of the public health emergency? So I will turn to Tricia and then Patty to help answer this question.
So I think we want to make sure that our communities of color and other at-risk populations are paid special attention to. So for example, making sure that notices are in languages that people prefer, working with navigators and community-based organizations that target communities of color or at-risk persons would be important ways for us to make sure that they don't lose coverage. We know that in particular for children, low-income children tend to be more disproportionately represented by communities of color. So, and Medicaid is so essential to early childhood development and school readiness. And so we need to pay special attention to them as well.
Yeah, I, would echo everything Tricia said. My other thought is how important it is to be engaging with consumers and their families, people who are in the Medicaid program with their families, with trusted community organizations that they relate to, whether it's their community health centers, faith-based organizations, and really engaging those community partners in getting the word out, communicating, even messaging as simple as, update your contact information with your state Medicaid agency. If you've moved, you want to make sure you can keep your coverage, renewal assistance, keeping an eye out for renewal notices. And, states built a lot of that infrastructure during the pandemic for their testing and vaccination efforts. And we really can be leveraging that infrastructure. And I would hope and urge states to be leveraging that infrastructure that they've built.
Yes, thank you to both of you. So now I'm going to turn to our next question, which was actually submitted in advance. So Tricia, can you say more about how the end of the public health emergency would affect CHIP?
Yeah, that's a great question, because the continuous coverage protection did not apply to separate CHIP programs. Now, there are two ways that states cover kids in CHIP. One is to use CHIP funding to actually cover those children in Medicaid. They have been protected. And about 2.9 of the 7 million children in CHIP are in separate CHIP programs. Now, the estimates are that of the 6 or 7 million children that might lose Medicaid, at about 2/3 of them will still be eligible for separate CHIP programs. That means that separate CHIP programs could actually double in size by this mass enrollment event. So when there are separate agencies that are handling CHIP, they need to be prepared for the influx. And I think that there are opportunities for states to remove barriers to smooth out those transitions. For example, eliminating premiums, or at least waiving them for a period of time during the unwinding until things settle down, I think would be a great start.
Thanks.
I think that's right. And just to maybe this is a stunning statement of the obvious, but I think as important as we all know and have always known children's health coverage is, our children are really in crisis in our country, and coverage is more important than it has ever been in terms of their physical and especially their mental well-being, and having access to services to help ensure their physical and mental well-being. So it feels like, I know I keep saying the stakes are high. It feels like for kids included, very, very high.
Yeah, I'm not sure you can overstate that. Thank you. So another question, and we can hear from both of you, is saying more about what federal policymakers can do, how they can support states preparing for the end of the public health emergency. And Patty, why don't I turn it over to you first?
So I would say, in terms of our partners in the agency, I think between Tricia and I, we covered a lot of it, that continued dialogue and partnership and cajoling, requiring that has already been going on is really important to continue. And in the spirit of partnership and hopefully rowing in the same direction in terms of the goals, I do think Tricia's right that there are going to be some areas where we aren't successful, and we do need transparency and to be able to put the brakes on unwinding activities that aren't going well in states. So that's sort of on the agency side. As far as Congress, I think Tricia and I were talking earlier and would both point to how important the ARPA subsidies have been, the extended ARPA subsidies have been in terms of coverage during the pandemic. And in order to transition people from Medicaid to affordable marketplace coverage, it really is essential and will be so helpful if Congress is successful in continuing those subsidies. That feels like another really important piece of the puzzle in terms of coverage retention and sort of holding this amazing ground we've gained on coverage in our country.
Yeah, I would agree with Patty, extending those premium tax credit enhancements and doing whatever we can do to boost the transparency of information so that we can monitor the underwinding is important. Also, if there are opportunities to increase dollars for outreach and consumer assistance, I think that would be extremely helpful. But since we're talking to a Hill audience, I would say to you all, encourage your bosses when they're on recess to go home and talk to their Medicaid agencies, to talk to their constituents who are on Medicaid, to get a real sense of the impact this is going to have on them, and to work with their state leaders to make sure that the state is pulling out all the stops to make it easier for people to either stay enrolled or to transition to other coverage.
I love that, Tricia, and I'm just going to make a shameless plug now for state health and value strategies. I think if states aren't accessing state health and value strategies resources, and I'll put them in the chat, they have a whole page, landing page on resources for states. They also are offering states direct technical assistance through people like me and other technical assistance providers. And so if your staff is hearing about problems on the ground in your states, send them to State Health and Value Strategies.
Thank you. Really important points from both of you. Turning to another question that was submitted in advance, are there sources of funding that can be used to promote equity in research interventions to provide financial support for people with low income?
I don't know.
Tara.
Go ahead.
Yeah,
Patty.
go ahead, Tricia. I was just trying to, I'm not sure I tracked the question, but maybe Tricia, you did, and I can riff off of you.
Well, I'm sure that they are, but it's not necessarily something that I have top of mind that I could respond to. Would be very happy to look more into it and offer some feedback that can be shared with people who registered.
Well, I can speak to the foundation is really looking to shift how we do research to really center people's priorities, especially people who have been furthest from opportunities like low income people. And so, we're looking at how we can drive research questions and research methodologies to really center these perspectives. So I'm not sure it totally answers the question, but we are looking at shifting away from traditional research methods that hopefully will look at how we can really center equity in research broadly.
And Tara, that just brings up a point that unfortunately the data that we have to work with around race and ethnicity as it relates to Medicaid is not as good as it needs to be. We need to work harder. I mentioned the MACPAC data on churn, but when you look at what states are reporting to the federal government, just a little over half of the states have reliable race and ethnicity data. So we really have to go back and work harder at the mechanisms to capture that information so that it flows in to all of the other data that we have in order to, figure out what works, what doesn't work, and what more needs to be done.
And I would just chime in to say yes to all of that, but not letting the fact that we have more than imperfect data be the enemy of doing the work, right? Like, yes, we all acknowledge that we have imperfect data, but we've got to use what we have. And I think while improving it, while doing things to improve it, and the federal government has a real role there, I think, but also, the qualitative input, the qualitative research methods to test, not assume we know what the data says, but rather test our conclusions about what we think the data says and policies to address it.
Now, there's another point perhaps to raise here about just even the concept of health equity that is not completely understood. Health equity doesn't mean taking away something from someone to give it to someone else. And more research needs to be done around how people perceive health equity and race and structural racism, and what more can be done to really move the conversation forward in a productive way.
Thank you. Yeah, really good points. So on next question, one of the speakers, I think this was you, Patty, mentioned a few states that are doing a particularly good job that could serve as models for others. Can she/you provide additional comments on that?
Yeah, I'm happy to, and I'm sure Tricia can as well. You know, and I'm sorry that California is my first example, because I know everybody thinks California is a unicorn. They just released publicly their plan for unwinding. So their operations, so CMS says to states, you all have to have an operational plan. Tell us what you're going to do, what you're planning for, how you're, tackling this huge effort. But states don't have to make it publicly available. I think that's part of the transparency that Tricia's talking about. California has just released theirs, made it publicly available, and they are, even beyond that, doing a lot of engagement with stakeholders around their plan, and have done a lot of engagement with states around their plan. Virginia has an unwinding toolkit that they've gotten out to their partners in the field, to their health plans, to providers, to advocacy organizations. I can also put that in the link to the chat, the link in the chat. Let me just see what other good examples I have. Oh, Hawaii is funding and working with their federally qualified health centers to train community partners to help consumers with application for renewals for Medicaid and application for Medicaid and Marketplace, which I think is a really smart idea, leveraging that training capacity at FQHCs. I think those are my top ones I have at the moment. Tricia, are there others you would point to?
Well, not to focus too much on California, I would say that they have a neat way of trying to engage the stakeholder community. They have posted information about becoming an ambassador during this period of time so that you can assist. I think that's a really unique way. And I apologize, I have my door closed, but my cat desperately wants to come in and see me. So if you hear any banging in the background, that is what is happening there. I think we've been disappointed at the amount of information that has yet to come out. Some of that is because, states, rather than engaging in the preparing process, they really want to deliver a plan. And they don't know when to deliver that plan because they don't know if they have all of the pieces of the plan together yet. We had a webinar with the Center on Budget and Policy Priorities on Wednesday. It's the seventh in a series of unwinding webinars. And we had 280 registrants. I'm not quite sure how many were actually on, but we conducted some polls, and only about 50% indicated that their state had said that they would commit to sharing the plan and would commit to sharing the data. So I still think we have a lot of work to do, and I think the more that we can lift up these examples, Patty is closer to those examples of the states because she's working directly with the states. But the more that we can push that out there as best practices and models, I think it will help others move along.
Thanks. We can't hear your cat, but I'm sure that he or she just wants to help with this very important issue, help with accountability. So the next question builds on where you both were discussing, which is as we think about states' preparation, and we know that it's expected that the public health emergency will be extended. So how will this impact state preparation efforts?
I'll start. I think that for the vast majority of states, more time is better. I think the extension of the public health emergency, especially when you consider we keep thinking we're emerging from the pandemic and then the numbers climb again and create a new set of issues. You know, all the same people working on these issues in states, or most states, you know, have very tight Medicaid and public health staff that are all working on these issues. So I think more time for preparedness is definitely going to be positive for states. I do think, as I mentioned earlier, that workforce is a particular challenge for states. You know, in an ideal world, we would say to states, the public health emergency is going to end on X date, and we would say that 120 days before X date, so that they would have the date certain that they're hiring against and they're training against. I don't think that's going to be possible. So I would just say more time is better, but acknowledging that not having the certainty, you know, continues to be a challenge.
Yeah, I definitely agree with that. But I think at least there's some contingency out there that thinks that this will actually go through the end of the year. And I hope that gives states a little more breathing room for some of the harder systemic changes that they need to make. I should call attention to the fact that we do an annual 50-state survey with the Kaiser Family Foundation on eligibility and enrollment, and the 2022 version, which was fielded in January, provides a lot of information about what the states were saying that they plan to do at that time. And one important piece, without getting too much into the woods, is this idea of being able to use data available to the state to automatically renew coverage or to verify eligibility at application. Using those data sources, let's use IT the way that it's intended to be used. And the more we can do that, it offloads that paperwork, that manual work that states workers have to do when they're handling paperwork. So, but states, I think early on, when we thought it was going to end this month and then it was going to end at the end of 2021, we're a little reticent about diving in to some of those systemic changes that are much more complicated and take time to test. Hopefully this gives them more breathing room. I think that Chevis and CMS have been making wonderful progress on this, but honestly, all this, there are about 42 states that were indicating they were continuing to process automated renewals during the PHE. Only 11 of those states indicate that they can automatically renew coverage for more than half of their caseload. So the more we can boost those numbers, the better things will be. Not only as, and this Patty brought this up in the original part of the conversation, not just now and in the unwinding, but going forward. And that's something we've been working on, hoping to improve for many, many years now.
Yes, so we are coming to the close of our session today, and I just want to extend a huge thank you to both of you, to Patty and Tricia, for your incredible insights and for all the work that you're doing that helps to inform those insights. And as you have so poignantly shared, we are on the cusp of what could potentially be a huge moment for coverage losses, but doesn't have to be. And I would just encourage all of us to think about what we can do in whatever role we're playing to center equity as part of the preparation for planning for the end of a public health emergency. And what do people need? What do people with Medicaid need? And also what do state officials need to help preserve and maintain coverage now and into the future. Thank you everyone who participated today. We appreciate all of your time and interest, and there will be a link to a brief anonymous survey in the chat, and we really appreciate you completing it. That will help us plan for future events, and we will also be following up by email with a recording of this webinar, the link to the survey, and additional resources. So thank you everyone. Thank you again to Patty and Tricia, and have a wonderful afternoon. Take care.